So let's begin with the auscultation. So what we use is the stethoscope. So you have the standard stethoscope that we have. So the stethoscope has various parts. You have the earpieces, then you have the tubings, then you have the diaphragm and bell that is there. So all these are parts of the stethoscope. But the most important part of the stethoscope is the part that is between the two earpieces. That means the head of the person. So that is your understanding, your interpreting. Unless you hear it something and hear it again and again, you will not be able to make the diagnosis. So auscultation is a blinded technique. Unless you hear it, unless you experience what it sounds like, you will never be able to make it. So again, though a lot of importance has been told for auscultation, I personally feel auscultation is a corollary. All your diagnosis of cardiology has to be made before you reach auscultation. Auscultation is just a corollary. It might add on certain small things, but your clinical diagnosis of what the patient is suffering from, what the complications the patient is having, should be done prior to you reach the auscultation. So a human ear can hear anything between 20 to 20,000 hertz. The sensitivity is best at 1,000 to 5,000 hertz. So the minimum gap to differentiate two sounds by a human ear is 20 milliseconds. So if there are two events that is happening which is lesser than 20 milliseconds, our human ear cannot differentiate it. Coming on to the various auscultatory areas. So we have already discussed these areas. Remember, the first mitral area, that's the fifth intercostal space that is there in the mid-clavicular line. Tricuspid area is the fifth intercostal space, lower sternal edge. The second intercostal space on the left side is your pulmonary area. The aortic area is the second intercostal space on the right side. The Erb's area, that's the neo-aortic area, is the third intercostal space. And the first intercostal space usually, or the second intercostal space usually, where the PDA murmur you get, that's called as the Gibson's area. And here you have the fourth intercostal space here in the lateral sternal edge. If you see here, that's where you can hear the VSD murmur better. That's why it is called as the Rogers area. So these are the areas that we have. So if you can remember the left side intercostal spaces, the first intercostal space is where you hear the PDA murmur. The left second intercostal space is where the pulmonary area is. The left third intercostal space is the Erb's area or the neo-aortic area. The fourth space area is the VSD area or the Roger area. And the fifth intercostal space is the tricuspid area. So that's in order. On the right side you have additionally the aortic area, and the fifth intercostal space you have the mitral area. So these are the areas that we usually auscultate. We can auscultate other areas. We have to auscultate some other areas, especially in coarctation of aorta, etc. We have to auscultate the back also. And the supraclavicular, suprasternal area, carotids we'll have to auscultate. Coming on to the characters of the cardiac sound. So you have two words that you have to remember. One is the loudness of the sound, which basically implies the amplitude or the intensity, whereas the pitch implies the frequency. So differences between the low and high pitched sounds or the frequency sounds. The low frequency sounds are the ones which have a frequency of less than 125 Hz, and the high ones are the more than 300 Hz one. So low pitched and high pitched. The characteristic feature of the low pitched sounds are the rough rumbling sounds, whereas the high frequency or the high pitched sounds are the soft blowing sounds. So this is what we have to understand. So what are the examples for the low frequency or the low pitched sounds that we have? The S3, the S4, the pericardial knock, the mid-diastolic murmur of tricuspid stenosis and mitral stenosis. These are the low pitched sounds. And please remember, for all of them we'll have to use the bell of the stethoscope, bell of the chest piece, we'll have to use it, and it has to be pressed very slow. Very important, you have to remember, how do we use the bell of the stethoscope, they say. So the bell, it has to be open, it should not have any rims there. So when it is being placed, it should not be firmly placed, it should be lightly placed there. So you have to hold the stethoscope with the stem of the stethoscope there, stem of the chest piece, and just place the bell there. Only then can you hear this low pitch sound. If you place it and press it firmly, the bell will become diaphragm, so you will not be able to see the low frequency sound. So remember the low frequency sounds: S3, S4, pericardial knock, mid-diastolic murmur of the mitral stenosis. What else is the bell used for? The bell is used for venous hum and arterial bruise. So remember, these are the uses of the bell. So in the exam they ask you, bell, what are the uses? S3, S4, pericardial knock, mid-diastolic murmur, venous hum and arterial bruise. In contrast, the high frequency sounds are best heard with diaphragm. All other sounds are high frequency. S1, S2, ejection systolic clicks, opening snaps, systolic murmurs of MR, AR, TR, all of them are high frequency, high pitch sounds which are soft blowing murmurs, and they are best heard with diaphragm of the stethoscope. That is what you have to remember. Topographical areas we have discussed already. The mitral area corresponds to apex. So remember, mitral area is not fixed. Wherever the apex is, it goes there. So apex is normally in the fifth intercostal space, 1 to 1.5 centimeters or half an inch medial to the mid-clavicular line, or 10 centimeters from the mid-sternal line. That's where the mitral area is. Tricuspid area, left lower sternal edge. That's the fifth intercostal space. That's where you get the tricuspid area. Aortic area is the right second intercostal space. Neo-aortic area, otherwise called as the Erb's area, is the left third intercostal space. Pulmonary area is the left second intercostal space. Axilla, sometimes you will have to auscultate the axilla, especially for the pansystolic murmur of mitral regurgitation, we will have to auscultate axilla. Epigastrium, the pansystolic murmur of tricuspid regurgitation, we will have to auscultate the epigastrium. And carotid, sometimes aortic stenosis murmurs conduct to carotid, and the carotid bruise you may be able to auscultate there. The two other areas that we discussed, the Gibson's area and the Rogers area. The Gibson's area is the left first intercostal space where you get the Gibson's murmur of PDA, and Rogers area is the left fourth intercostal space where you get the VSD murmur.